Welcome and good afternoon, everyone. Selamat datang and thank you for everyone joining the 12th Secure Webinar Series hosting by the Asian Development Bank. Today's webinar's theme is Strengthening Health Surveillance and Diagnostic Capacity in Indonesia. My name is Rabia, and I'm the National Health Security Expert for Indonesia for the TA6767, and I will be your moderator for this webinar. This webinar is the part of the Secure Webinar series, which is supported by the Technical Assistant TA6767 and used as a platform to document, disseminate, and promote knowledge exchange and best practice for strengthening health security post-COVID-19 pandemic in Southeast Asia, developing member countries of the Asian Development Bank. I'm hoping whenever you are joining today, you learn and get benefit by listening and posing questions later from our panel of experts today. In the face of numerous challenges, the COVID-19 pandemic has prompted unparalleled level of system integration within the Indonesian government. The post-pandemic health system transformation agenda outlined by the government Indonesia emphasized the intention to standardize an integrated model of primary care and bolster surveillance, diagnostic capabilities, and public health laboratories. Today, we will explore and discuss Indonesia's current diagnostic and surveillance capacity and its transformation. Firstly, we will hear the welcome remark from Ms. Karin Selsik through a video recording. She is the Director of Human and Social Development Sector Group in Asian Development Bank with 25 years of multidisciplinary human and social development experience in East and Southeast Asia and the Pacific. Please play the recording.
On behalf of the Asian Development Bank, I am pleased to extend a warm welcome to all participants joining us today for the 12th ADB Secure webinar on strengthening health surveillance and diagnostic capacity in Indonesia. Thank you for joining us for this knowledge-sharing event that aims to distill lessons from the COVID-19 pandemic. The pandemic highlighted stark global disparities in diagnostic capabilities and underscored their pivotal role in effective pandemic response. It quickly became evident that investing in diagnostic testing capabilities and in robust health surveillance systems was critical to addressing the pandemic and to building resilient healthcare systems that can respond to future disease outbreaks. Like many ADB developing member countries, Indonesia faced significant challenges during the pandemic, experiencing 3 major outbreak waves. By the end of June 2023, Indonesia had recorded more than 6.8 million confirmed cases and nearly 162,000 confirmed deaths. Indonesia's experience showed a critical need for better health surveillance, diagnostic capabilities, and public health laboratories. Indonesia's commitment to strengthening health security is evident in the country's innovative health system transformation agenda, which includes standardizing an integrated model of primary care and bolstering surveillance capabilities, diagnostic capacity, and public health laboratories. ADB has provided a comprehensive package of support to the health system transformation agenda with technical assistance, policy-based lending, results-based lending, and investment lending, all approved toward the end of 2023. We are also supporting or planning to support other developing member countries to strengthen their public health laboratories and to increase access to quality diagnostic tools. In today's webinar, we're pleased to be joined by experts who will set out to do 3 things. First, share insights on the importance of strengthening health surveillance and diagnostic capacities. Second, explore and understand the current diagnostic and surveillance capacity in Indonesia. And third, discuss recommendations and the way forward for enhancing Indonesia's existing control measures and preventing future disease outbreaks. I hope this webinar will be a platform for knowledge exchange as we aim to work collaboratively toward ensuring access to affordable and essential diagnostic tools that are fundamental for resilient health systems in Southeast Asia and the Pacific. Thanks again for joining the 12th in our series of secure webinars.
We will hear soon the presentation from our experts, and we'll have a discussion session later at the end of 3 presentation. You can post your questions on the Q&A box, and we will address the question later by order, or you can also ask your question later in the Q&A sessions. Our first panel of experts today is Prof. Chandra Yoga Aditama. Prof. Chandra is a postgraduate director of Yarsi University in Jakarta and a professor in University of Indonesia. He's also the member of expert team of Indonesia President Advisory Council. He was a long-serving Indonesia Ministry of Health officer, served as Indonesia Director General of Disease Control and Environmental Health, and Director General for National Institute of Health. The first presentation will run for 20 minutes. Thank you for agreeing to share your insights today. Prof, please, Prof. Chandra, whenever you're ready.
Thank you, Rabia. May I share my screen?
Yes, please.
Am I audible and the screen is okay? You are mute, Rabia. But anyway, so distinguished colleagues, ladies and gentlemen, first of all, thank you for having the opportunity for me to share this presentation in this important webinar. And also, because the topic is about Indonesia, I'm the only Indonesian in the panelists. I would like to thank ADB for supporting Indonesia in this regard. So, we all know that Indonesia is quite a wide country, a big country, and then I just put the Indonesian map on top of US map, and it's Indonesia as wide as from the west coast to the east coast of the United States of America. This is if we compare to America, and this is comparing it to Europe. I used to know that Indonesia, from the west to the east, is something from London to Vladivostok, but you can see here. Anyway, it's as wide as Europe as well. The total population is more than 270 million people, I think we all know. And then now Indonesia have 38 provinces and 514 districts. So of course the health office is in each province and each district. And throughout the country, there are more than 10,000 primary health centers working, in the sub-district, and about almost 3,000 hospitals. And there is also integrated service lower than primary healthcare. So this is in general what the system, health system is available for the country. As mentioned earlier, there is a health transformation. Health transformation is now going on. It is in line with the president vision of oh, sorry, I need my glass. Vision to create healthy, productive, and independent and fair. So there are 6 type of transformation is going on. One is primary care, secondary care transformation, health system resilience, health financing, health talent transformation, and health technology transformation. Of course, almost all of it are related to our discussion, but I just highlight at least 3 or 4 that are closely related with our topic of discussion today. First one is regarding public health laboratory. Secondly, about priorities disease service network, and then strengthen emergency response resilience, as well as the health technology transformation. So based on this one, as mentioned, ADB support Indonesia for this health transformation as well. Now let's see let's see the outbreak report that was collected by the Ministry of Health so far. This is from 2018, 19, 20, 21 until 2024 up to February only. So you can see before COVID, about 300 every year. But of course, during COVID, it's going down because people are talking about COVID. But now it's increasing again. And last year is already, more than 400 outbreak reported or captured by the Minister of Health, which include various vaccine preventable diseases, food poisoning, zoonosis problem, vector-borne, acute watery diarrhea, direct transmission, and others. These are some diseases that was captured by the outbreak response from 2018 to 2024. In Indonesia, there is a ministry regulation. So 17 of these are under ministry regulation, which is a type of infectious disease that should be reported. But now we added another 7, so it's 24 diseases that under the radar for infectious disease in the country. So my first slide is about the number of outbreak. Now I will tell you number of source of the report that the Ministry of Health received. So Puskesmas, so primary health center is this one. So hospital, labs, and also port health office. So it's about more than 11,000 healthcare facility that report on the early warning and alert response system. Beside from the health facilities, of course, the surveillance activities also get information from media, social media, or other program, or even directly from community. So from all of this, all the information gathered to be analyzed later on. In general, we can say that early warning was or is was performed through two type of surveillance, event-based surveillance and indicator-based surveillance. So event-based surveillance, the disease the is already there. Then there after that there is a verification and then further verification, etc. But for indicator, there is still indicator. Then and we have to find what is the case definition, and then later on it's investigation, etc. And then of course the last step will be response to this outbreak that was reported. Sorry, this is in Indonesian language, but basically there is a central server in the Ministry of Health that capture everything, every information from the field, from uh, uh, primary healthcare center or from hospital, and then it is directly distributed to district or province or in the Ministry of Health. And of course, after information received, there is the verification of validation process. And if there is some outbreak needed, then feedback is given to all of the health facilities is concerned. No, we all know that One Health is an important part of disease control. So this is just to show you the interoperability, signal sharing between human, animal, and wildlife sector through, we call it CISA application. So the human health is go into this light blue. This is the Indonesian word for SKDR, and the blue one is for animal health. So this one, and this is for wildlife. So this one, all together into this integrated system, interoperable system, and then after that, of course, alert receivable system, verify, collaborative, and report, etc. So this is a real One Health surveillance activities, but as of now, is only into for these four diseases, avian influenza, rabies, anthrax, and leptospirosis. It will be expand in the coming time. This is just a report. I mean, an example, colleague, ladies and gentlemen, how the central government trying to monitor whether uh, these are the list of provinces. There is my cursor. These are the list of provinces. It is 38, as I mentioned earlier. So the one in green is the provinces who submit their report on time. The one is in yellow is provinces who submit the report but late. So this is every week, as you can see above. The red one is the province who did not submit their report. So this is the way that the central government monitor whether information from the province will, will, will come to us. And also, there is also another one from province to district as well. Based on the data from, I think, 2014 or 15 up to now, then the Ministry of Health uh, publish this kind of Indonesian hazard calendar. So dengue usually happen in this month, and then so if we like now dengue is happening here in Jakarta. So if you want to do preparation, it should be during the green time. So or at least something in yellow, but please do it here so we can be prepared for the when the outbreak is happening moderate, low, or high. For each of the diseases, dengue, chikungunya, etc. But not only diseases, also some natural disaster like flooding or landslide or drought or forest fire that will impact health. There's also a calendar here, so people will know usually which months forest fire happening and when we should prepare for the quote unquote next forest fire. So these are basically the uh, emergency and alert warning system. Now let's go to the restructuring of public health laboratories, as already mentioned as well. So there are like any other country, there are 5 tiers of public health laboratory: tier 1, tier 2, tier 3, tier 4, and tier 5. So tier 1 is basically in the more than 10,000 public health center, and the tier 5, the highest. We have two now in the country. One is the National Lab for Clinical Specimen for environment, factor, and reservoir. So there are two, one in Jakarta, the other one in Salatiga, and this tier 5 can do all of this one, and maybe tier 1 will only do screening, diagnosis, and follow up, and some are surveillance. So this is basically the restructuring of public health laboratories, the one in the box that I mentioned in the earlier slide. This is distribution of public health laboratory in Indonesia, spreading almost all over the, yeah, I should say all over the country, even though in Papua you can see not so much, but anyway, so it's spreading all over the country. This is saying about Pier 5, Pier 4, Pier 3, etc. This is what the 14 activities that we need public health laboratory should do for each tier. So tier 1 will only perform 1, 2, 3, 4, 5, and tier 5 has to perform all of it. Has to tell you that not all of it already perform properly, but actually this is the need that we have to do in the country. So sorry, this is too small, but any just to mention to you for testing activities, what should be done in tier 1, what should be done in tier 2, what should be done in tier 3, etc. For quality assurance, what should be done in each of the tier. For environmental tests, for vector and reservoir. Sorry, this is repetition. And for calibration, what each tier should be done. So it's already in detail, clearly mentioned in this slide. And this is the kind of diseases or activities that should be done on the highest burden, infectious disease, environmental health risk, etc. And all of the system now in progress to be included in this system. I mean, the one in the middle. In Indonesia, it is called like where is Satu Sehat. Satu Sehat literally means one health, but this is not about one health that we know, animal, human. But this is anyway. This is in national system information system that will be used for everything in the country, including later on, including personal data. But now still in process. But you can see all of the health facilities will link into this Satu Sehat. So the public health laboratory is not working by themselves. They have to make a network, of course, network to with medical health laboratories, environmental health, also non-health laboratory by government as well as by private sector. The networking can be done including this kind of activities. So all of this will be networking with the Labskesmas. This is the public health laboratory. This is for One Health, more or less the same like I mentioned earlier. There is a networking between public health laboratory with veterinary laboratory and environmental laboratory. So in general, regarding public health laboratory, the challenge is, this is a big country. So from one place to another, there is a huge discrepancy among labs, among local government, etc. So I think this is the main challenge. Of course, there is also a challenge of logistic. Some or most of logistic is also important, and also there's also a challenge of the lab personnel. but we have several, I mean, at least two important factors for success. One is the political commitment. As you see, the transformation is quite clear. So political commitment is there. And you may know that Indonesia has just finished the general election, so we'll have a new president in October. We do hope that whoever the minister will be, but commitment will still be there for for the health security. And the other factor for success, we have already more than 10,000 public health laboratory, the tier 1 to tier 5. So my last 5 minutes will be clearly talking about the laboratory-based surveillance. I'm sorry, again, it says in Bahasa, but just to mention, this is just a process, as you know, if there is a suspect of cluster or people with risk factor, and then we check whether it is included, I mean, in, uh, in the operational of definition of the disease, then specimen was taken, and then take the sample, etc., and then do do the response. This is just a basic laboratory-based surveillance. As of now, existing, the laboratory-based surveillance is in this one. Arbovirus sentinel surveillance for dengue, chikungunya, Zika, and JA, and also leptospirus sentinel surveillance, Ilisari, and another. And in the near future is this one: typhoid, diarrhea, pneumonia, and SFMD. You may know that these days SFMD is quite prevalent. I mean, at least from the media, parents are complaining about SFMD for their children. So these are the existing one, and this is the coming one that will be established. Again, this is a map. You can see from each of this province can do J and Plasmodium nilosi, for instance. This province can do this one, etc. So in detail, it's already spreading throughout the country. This is just example. This is Ili and Sari that we submit to the FluNet and Flu ID. So for Ili and Sari, there is 39 public health center for Sentinel, Sari certified hospital, and Ili 14 point of entry. These are the target for them to submit. I just discussed with my colleague in the Ministry of Health. Not all of the target already, being performed, but anyway, this is the target and what should be done. So, for instance, for primary healthcare, of course, they have to refer the sample to the public health laboratory tier 4. For SARI, for public health tier 4, they have to do it by themselves, or some hospital can do it. For point of entry, they have to refer as well. This is just the same like that one. So primary healthcare, this is port of entry, also hospital. They have to refer to regional public health laboratory and do check for PCR, influenza A, influenza B, and if it is negative, go for finding another pathogen by national public health laboratory. Just example that we submit to Indonesia submit to FluNet and Flu ID. You can see the subtype of influenza A, influenza B. This is basically in line with global data. And also during COVID, we all know that whole genome sequencing become very important. So these are the whole genome sequencing lab throughout the country that was built during COVID-19. Now, since COVID-19 is basically under control globally as well as Indonesia, we are trying to use this whole genome sequencing for other diseases, so we can perform the diagnostic lab better. So as I said, this is basically from COVID. Then we submit the data to GSAID as well. So you can see here, I think this dot is talking about Indonesia. So data from those whole genome sequencing submitted to GSAID, and these are the report of variant of COVID-19. So my 3 or 4 last slide is talking about the support. This is the support that we receive from WHO. The publication of WHO Indonesia on 29 February saying that there's a need to develop a comprehensive transition plan, improve detection capabilities, evaluate the system, and bridge the gap in data analysis and utilization skill. So basically, this is the one that we will discuss today. So it is already support. I mean, in Indonesia has done a lot of things, will be supported by WHO, and support by ADB as well. So the project of ADB outcome will be equitable access to primary care and public health laboratory service for prevention, detection, and treatment of communicable and non-communicable diseases. So we thanks also, I mean, of course, we thanks the WHO and ADB for their support. Colleagues, ladies and gentlemen, in my last 1 minute, I just want to share with you. I attend the INB 9 meeting talking about pandemic treaty. I'm sure all of you read this publication in Lancet on the 2nd of March. So it is clearly said that convention is now at critical juncture. It is that one. So after the INB 9, this is the meeting during INB 9, and of course there is still discussion talking about equity, fairness, transparency, etc. But yeah, at the end of the INB 9, if you want to see positively, member states agreed to resume negotiation. That means that the negotiation INB 9 is not yet clear, it's not yet come to conclusion. So there will be a resume negotiation. And Dr. Tedros mentioned, I thank them for their clear commitment to finding common ground. So this is kind of diplomatic way to say it's not yet there, a common ground, but hopefully the ground will be there, the common ground will be there. Anyway, this is the office of the chef of the cabinet of WHO. It's not my office. I just happened to make a photo there because the chef of the cabinet is Dr. Razia, which is my colleague during in Seattle. So my last slide, distinguished colleagues, ladies and gentlemen, sorry, this is in Bahasa. I just clearly mentioned here that we are sure there will be a next pandemic. We only not sure of two things. We do not know when, and we don't know which disease, whether it is zoonosis, whether it's a corona, whether it's a pandemic, or whether it is disease X, we do not know. But we are sure that there will be a next pandemic, and there will be a next outbreak. So we have to be prepared. And I do hope that this webinar today will help Indonesia to better prepare for outbreak as well as better prepare for next pandemic. Thank you so much. I think I 21 minutes. Sorry, 1 minute more than the time allocated. Thank you.
No, thank you so much, Prof. Chandra, for valuable insights and such a comprehensive presentations. The next presentation will be presented together by two of our panel of experts. They are Professor Rosanna Piling and Professor David Heyman. I will introduce both of them together before the presentation, since they will do this presentation together. David Heyman is the Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine and a distinguished fellow at the Center on Universal Health at Chatham House, London. David was the chairman of the United Kingdom Health Protection Agency and was the chairman of Public Health England. He was the World Health Organization Assistant Director General for Health Security and Environment and representative of the Director General for Polio Eradication. The next expert is Professor Rosanna Piling. Rosanna is a professor and chair of diagnostic research at the London School of Hygiene and Tropical Medicine and director of the International Diagnostic Center. She is trained as a medical microbiologist and had been research coordinator and head of diagnostic research at the UNICEF, UNDP, World Bank, and WHO TDR in Geneva, Switzerland. She was also the chief of the Canadian National Laboratory for Sexually Transmitted Disease before assuming her current position. This combined presentation will run for 40 minutes. Thank you so much, Rosanna and David, for agreeing to share your insight today. Please, Rosanna and David, whenever you're ready, please share your presentation. Thank you.
Thank you very much, Bia. It's really a pleasure to be with you, and I'd like to thank our colleagues at the Asian Development Bank and also our colleagues in Indonesia for having hosted us during what we found was a very interesting activity that's going on in Indonesia, and that is the transformation of the health system. What we just saw from Chandra is really showing what an excellent base already exists in Indonesia for really a strong surveillance system which can detect and respond to infections when and where they occur. What we did was we had a possibility of reviewing several documents before we came to Indonesia, including Chapter 5 of Health on the Indonesia Public Expenditure Review from 2020, and the Indonesian Health System Transformation slide set that was on the website, as well as a project done by IFRC on community-based surveillance, and the excellent EWAR system that Chandra discussed with us earlier. So we had a good background of information before we arrived in Indonesia. And then on the 7th and 8th of September, we had the opportunity of discussing with many colleagues in the Ministry of Health, also the ADB, UNICEF, and Fine Diagnostics, all being present in Indonesia. And just as a summary before we begin, what we found was that in order to have more equitable access to surveillance and laboratory support, there are some new technologies which Indonesia may want to consider in order to make surveillance more cost-effective and laboratory more cost-effective, and possibly even prevent having to construct physical laboratories at certain centers where they were planning to do that in the past. So what we looked for in our assessment was equitable access and modern technology to really help Indonesia begin to shift surveillance to where disease outbreaks really occur and where the response is necessary immediately, and that's at the community level. So with that, Rosanna, maybe we could start with the second slide. I've lost the slide. Do you have it? Is it on the screen?
Yeah, I just need to share screen again because it doesn't
please.
allow me to advance it. So let me do that again
Okay.
and see if, okay, great.
Okay, good. So what our tasks were that we discussed with Bia, and again, thank you, Bia, for your strong support during this activity. These were the tasks that we were told that we would review. First, the organizational structure of the public, private, and community-based health laboratory facilities. And this first task is really important because private sector can provide a lot of information and a lot of support, yet oftentimes is not included in the systems where they could be providing that. And this is not in Indonesia, this is just as in general throughout the world. Second, assess public health laboratory supply chain procurement, governance and quality assurance, and gaps in expanding capacity in diagnostics and surveillance capacity. And we were able to review some of the plans for doing that. Provide tailored recommendations to strengthen diagnostic and surveillance capacity, which we've done. And finally, provide inputs to the ADB support for acceleration and resilience of the HSTA project. So if we could go to the next slide, what we did was we concentrated on the technological advances in surveillance and diagnostic testing that have come into use in the last 20 years after there's been widespread access to the World Wide Web, to digital mapping, to handheld surveillance devices. And what you can see here is that from the very beginning, when von Leeuwenhoek identified microbes under the microscope in 1676, we've come a long way with laboratory, first of all, laboratory skills that permitted culture of virus and bacteria, molecular cloning, and a few other things, up to the current status, which can bypass many of these very costly and time-consuming activities to actually have at our fingertips a result from PCR and from genetic sequencing and other activities that can be done now at the very local level with handheld devices and point-of-care testing. Next. So these are some of the activities that could be done. What's very important today is participatory surveillance and disease reporting. Everyone now who owns a mobile phone with capacity to communicate can actually participate in surveillance. So it's not the exclusive right of health facilities. Anybody who has a mobile phone can really participate in activities. And here are some of the available forms that are on mobile phones throughout the world. There are weekly reports of common communicable diseases, weekly reports of uncommon diseases. Sometimes these are in real time. Users can register, can download new forms, and can actually participate in surveillance, as we'll see going through the presentation. Next. In fact, this is in the US, what's called Flu Near You, which is a participatory surveillance system using smartphones. The data is collected on smartphones and web applications from community members who report when they have signs and symptoms of influenza-like illness. So community members who enroll in this program can provide information to the next higher level, which is the primary healthcare facility. There's no laboratory testing associated with this system, but the action is immediate. There's local, regional, and national collation of the signals, and then any necessary action is done. Next. This system takes advantage of digital mapping, and what you can see on this digital mapping from out in California in the US is that there is a concentration of influenza-like illness activity, which is circled in the San Francisco area. This circling was an area which is still blue in most parts, which means that it's what's expected, but there is an increase. The yellow shows you that there is an increase in reporting of influenza illness above the normal threshold. So what this tells the Flu Near You system is that there needs to be local action immediately to investigate and find out what is going on. Are all of those yellow reports really influenza, or are they something else? Could they be an emerging infection, which, like COVID-19, could cause a pandemic? So the actual reporting and digital mapping take it to the community level, to a very granular level, where there can be rapid and immediate action. I like to always say, you need to find the disease and respond when and where it's occurring. Next. At the same time, in Thailand, just neighboring Indonesia, they've developed a system for the animal health community, for the farmers who are working with domestic animals. And this is a smartphone and web application for community members in the agricultural sector or elsewhere to report unusual animal disease events or environmental hazards. Laboratory testing is actually done by the public health laboratory in the local community area, many times using point-of-care diagnostic testing that can rapidly, within an hour or so, have them understanding what's going on and leading to a local response from the health experts in the community to either respond immediately or request support from the next higher level of primary health care. Next. So community-based surveillance, as we're talking about, is very prominent now in many countries. In fact, we reviewed 19 community-based surveillance studies, which were summarized in the article that's cited at the bottom. And what those systems told us is, first of all, that there need to be dedicated surveillance workers at the community level who have mobile technologies, who are able to understand what a case definition is, able to understand, as is done in the EWAR system, what needs to be going on. At the same time, we understand that the communities need to be engaged, next, and also that there is local ownership and trust of any system. So an engaged community might be a community in which they've provided the names of people who they feel should be reporting for the community. Those people are trained by the national surveillance system to use case definitions such as ILI and report locally and upwards so that there is a rapid detection in communities. This needs to be integrated with other services as the EWARs and other services next. And also there needs to be effective communication, because communication locally can help communities respond rapidly. Next. Also, there need to be simple and adaptable case definitions. The ILI, influenza-like illness surveillance definition, is one of those. And next, and they need to be adapted, and there need to be adapted laboratory technology that Rosanna will speak about later, and quality assurance. And finally, this permits real-time decision-making and action. So by having strong community-based surveillance, you will have a system which can actually detect and respond in real time. Next. Thanks, Rosanna. So to look at community-based surveillance, it's detection and reporting of public health events within communities by community members who have been trained by the public health system. And examples in the world are endemic disease surveillance for avian influenza, COVID-19, dengue, measles, rabies, TB, anthrax, diphtheria in Indonesia. These are the diseases in your EWAR system. These are endemic diseases that need to be reported sometimes very rapidly in real time, and the response must be in real time as well. There's influenza-like illness surveillance we heard about. Community-based reporting can enhance this system. And there's fever surveillance going on where there are arbovirus Zika testing, including for pregnant women in countries such as Senegal and Uganda. So linking laboratory, point-of-care laboratory diagnostics, inexpensive really and cost-effective, to reporting in communities can really make the pyramid that you see on the left, which is strong community-based surveillance and health promotion and risk reduction as the foundation, moving upwards and reporting into the active surveillance system. Next. The UK has set up a very interesting digital surveillance and threshold system. And as you know, in the UK, they have the National Health Service, which has a service where people can telephone into a health line that's manned by nurses and emergency department persons 24 hours a day. And there's a record of this that's put into emergency department records or into the records of that group, which permit then to have scanning of that data every 24 hours. So information put in by nurses, information put in by emergency department records has been made available to a web scanning device. And this device uses over 300 clinical algorithms to focus in on certain syndromes which are considered very important, such as colds and flu or influenza-like illness, fever in children 5 to 14 years of age, vomiting, and the daily records are monitored for 10 syndromes actually, including these 3 and others. And when the system shows that the threshold has been passed, as in the vomiting where it's now red, there will be local action to investigate based on a standard protocol. This system has first of all established baselines of the preceding 5 years for these syndromes, looking at what was reported in the 5 years before the system was set up, establishing baselines, and then this barometer system, green, yellow, red, tells them when they need to act. Every 24 hours, there's a new barometer put out, and if that red area is showing up as being important, there's then action with standard investigation, including diagnosis to determine what the cause is. Next. And finally, environmental surveillance has been shown to be very important in COVID-19. And it was developed, as Chandra knows very well, in the polio eradication program. And what this shows you is the closed sewerage system in Egypt, in Cairo, and they focused on one area where there were reports of flaccid paralysis. And what you can see here is that there was wild polio virus identified in the system, in the sewerage system, up until a period of time when it disappeared. When it disappeared from the sewerage system, it also disappeared from the human system. And so polio was considered to have been eliminated in that area, and in fact it was. What you see, though, is that the blue Sabin poliovirus, which is the vaccine virus, continued to be detected in the sewerage specimens throughout the period, showing that the system was still working, but that the wild poliovirus was gone. Also, this is useful in open sewage systems, as was done in Mumbai and in many parts of India, where they also have been able to follow polio eradication. Now, these systems next were also developed, as you know, Rosanna, also used to determine whether or not COVID-19 was increasing in countries such as the US, Germany, New Zealand, and Finland. And so they tacked onto their environmental surveillance for polio. And as you know, the US did find polio in their environmental system in New York, as did London. So tacking onto their polio systems in these countries, they have been able to use them for COVID-19, SARS coronavirus 2, and these systems will be very useful in the future. Next, because this shows the variance. Here's the variants that are occurring in wastewater in countries where environmental surveillance is going on. So next, so what I've tried to do is just to show you in surveillance how community reporting can be incorporated into a surveillance system, add value, and make sure that there's more equitable access to disease reporting possibilities. So Rosanna, I'll turn it back to you now for the future. Rosanna?
Okay. Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. So I'm going to take over and talk about diagnostic technologies, and the future is here. In the days gone by, a lot of the testing was done in laboratories. We have lab notebooks for recording the results. And then we have paper-based sort of surveillance systems where we fax results to a central system. But of course now, there's rapid diagnosis that can be done outside of laboratories, and there's real-time reporting from labs, as well as readers that could read point-of-care tests that are done in communities, so that we will have not only diagnosis coming from the lab system, but also from the community. Now, years ago, I was asked by Nature to write an article on what kind of diagnostics we need for the developing world. And I coined this acronym, ASSURED, as I guess, ideal characteristics that we want from a test. A, for affordable, sensitive, specific, user-friendly, in that it can be done in a few steps, simple steps. Rapid, in that it could give a result within 30 minutes to an hour. Robust, so that it could be shipped at room temperature and stored at room temperature, and preferably equipment-free, or operate on equipment that could use solar energy or batteries, and then deliverable to those who need them. And so ASSURED is the acronym that I coined to stand for the 3 A's of diagnostics. We want accurate diagnostic, we want accessible diagnostic so that we could reach as many people as possible, and also affordability also adds to the equity. And so we saw during the COVID pandemic that a lot of diagnostics were neither accessible nor affordable, even though we have PCR. A lot of countries cannot have them, and enough reagents to do PCR, or have enough laboratories that could do PCR. So 15 years later, Nature asked me if ASSURED is still what we want. But I think what we like to do is not only to have assured, but also to have real-time connectivity for diagnostics and ease of specimen collection so that you don't need very specialized machines or trained personnel to collect the samples. And that adds to the accessibility and of the tests. Now, we know throughout the COVID pandemic that we need different tests at different times for different patients at different stages of their disease. So it's really important, even though we know that PCR is highly sensitive and specific, but if you use it on a patient that has recovered, maybe for another 3 weeks, the patient will still test positive by PCR. So in order to ensure a safe environment for communities to go back to work, for reopening of schools, we have to use the antigen test because we were lucky that we have antigen tests that could detect people who are at risk of transmitting disease. And therefore, we use a negative antigen test as a means of ensuring a safe environment for everyone to resume mass gathering and schools. And so different tests have different uses at different times. And so it's really important to be able to utilize tests for the right patient and the right time, either with laboratory tests that require big instruments, that's high throughput when you do a lot of testing, or individual lateral flow rapid tests that you could do in communities or even at home. And now there are multiplex rapid antigen tests that communities can use with ILI surveillance samples, because you could detect SARS-CoV-2 and flu A and B in a rapid test within 15 minutes. Now, for dengue, that is also quite different in terms of the kind of samples that you use and what tests to use. And because the period of viremia for dengue virus is very short, it's about 3 to 5 days after the onset of symptoms. So rarely would people go to their doctor during that time. So most of the doctors, by the time they see their patient, may not be able to find, even if the patient is infected, may not be able to detect the virus from the patient. So there are different ways depending on when the date of onset of symptoms are. You can use viral isolation, nucleic acid detection, antigen detection. These are all available as both lab-based instruments or as point-of-care formats. And there's also seroconversion for both IgM and IgG. And so there are now also multiplex tests that could allow the clinician to distinguish between dengue, chikungunya, and Zika. And also they added NS1 antigen, which actually will be able to confirm the presence of dengue because there's a lot of cross-reactivity between different flaviviruses. And so that if a person is infected with dengue or with Zika, it's really impossible to tell by having an IgM test alone. So having an antigen test together with an antibody test allows the confirmation that a patient has dengue. And so there are now, and in the right-hand corner, you could see that there are readers that click onto the rapid test that could allow you to have not only automated reading, so that you don't have to try and figure out whether the line is there or not, but also these readers have data connectivity so that the data could be transmitted to a central database at any time. Now, there's been in the last decade an explosion of near point-of-care molecular platforms, and here are some of these platforms. These instruments are very small, and most of them would only do one test at a time, and it's only requires 2 to 3 minutes of hands-on time. The rest of it is sample in, answer out. And it takes between 5 minutes to 75 minutes to get a result, depending on the technology. And all of them have data connectivity. And several companies have now developed multiplex testing. And so there are respiratory panels, gastroenteric panels, fever panels, neuro panels for meningitis, etc. And some of them have as many as 23 targets, targeting 23 different diseases. And all of them are you could use with complement syndromic surveillance and to monitor trends and be able to confirm outbreaks at source, rather than having to send specimens to a central database in order to confirm an outbreak. Now, putting all these technologies together, this diagram here is from WHO hepatitis testing guideline in 2017. And at each level of the lab system, of the healthcare system, you could see that there are laboratory nucleic acid technologies as well as point-of-care technologies that could be used in the first 3 levels of the lab system. And then in the communities, in primary care and within communities, mostly you could use only a rapid diagnostic tests, but it could be antibody tests or antigen tests or a combination of them. So I think post-COVID, what we would recommend is that countries develop a connected surveillance system as the backbone of a healthcare system to monitor trends and provide early alerts of outbreaks. And how do we do this? We want to make sure that there's appropriate technologies at every level of the healthcare system, and that the community-based surveillance that Professor Heyman talked about can be complemented with rapid testing within communities, and that we need to invest in people, more IT and informatics expertise, more laboratories and epidemiologists working together and as teams. And then we need to invest in digital systems for real-time reporting, and that all the point-of-care testing done in communities are read with readers or data connectivity, maybe with a mobile phone if there's an app for it, and connected to lab systems so that you have an end-to-end connected diagnostic system that serves as the backbone of a surveillance system within the healthcare system. And so with algorithms that are based on artificial intelligence and machine learning, countries should be able to detect unusual trends very early and provide alerts of outbreaks, but also to be able to monitor the effectiveness of control interventions for any disease. Now, a word on genomic sequencing. The technologies has gone from huge machines that takes days and days to sequence a genome, now to handheld instruments, as Professor Heyman has said. And these handheld instruments are able to provide the data within a few hours. And the cost of sequencing has come down dramatically over the last 10 years and 20 years. And now I see advertisements from companies that advertise that you could have a small sequence done for $29 US in a day. And so these are kind of technologies that we need to be thinking about to incorporate at the lower levels of the healthcare system. Now, a word about quality systems for laboratories. WHO has developed a stepwise laboratory quality improvement process towards ISO accreditation. And the acronym for that is SLPTR. And the SLPTR checklist is meant to determine if a laboratory is providing accurate and reliable test results on a timely basis, to determine if the lab is well managed and adhering to good laboratory practices, also to identify areas for improvement, and also the checklist serves as an input to generate laboratory-specific plans. And so in Africa, that's been used extensively, not only to check laboratories that are existing, but also as a means of building laboratory capacity and making sure they're on track to being certified as adhering to good laboratory practice. And for this, we need to make sure that the right specimens are collected and that they are transported to the lab in the appropriate conditions. And then within the laboratory, there needs to be staff needs to be licensed to conduct the work. And also there should be external quality assessment or proficiency testing of the staff to make sure they know what they're doing. And there should be guidelines to say what kind of tests to provide for what kind of condition. And with that, then you get an accurate result. Now, for point-of-care tests, it's really important to make sure that there is still a means of making sure that the healthcare workers are being able to do the test proficiently. And so we advocate for a point-of-care testing program must include quality assurance as part of its budget and not added on as an extra. And so this is really important. And in terms of point-of-care tests, we say that you need to think about quality as a continuum because you are able to, you need to be distributing the tests throughout the country. And with Indonesia, that's a huge over long distances. So it's really important that the quality continuum is maintained from the moment you purchase the test to make sure that the lots that you got are good quality, and that can be done by the National Reference Laboratory for the quality assurance, and then to make sure the quality of the testing and the quality of the tests are up to scratch. Now, with that, we will go on to our recommendations. The first review is of the organizational structure of private, public, and community-based health laboratory facilities. There's a uniform and standardized list of diagnostic tests that often do not reflect local epidemiology and needs. We also found that the diagnostic testing formats are not really tailored to the laboratory skills of the staff, and that the relationship of public and academic or private laboratories are not clear. And also, we're not clear what the surge capacity would be for diagnostic testing should there be an outbreak. So our first recommendation is for Indonesia to establish epidemiology units to facilitate geographic mapping of disease burden so that we can ensure that there's the laboratory capacity that and technologies that are appropriate for local needs. And that we like to see the National Reference Laboratory have a program to oversee all laboratory and point-of-care diagnostic services. Right now, the National Reference Laboratory is doing a really good job of overseeing the entire laboratory network. But I think that if we add more point-of-care diagnostic services at the bottom of the healthcare system, they need to be connected to the rest of the system. And the National Laboratory needs to make sure that that tiered diagnostic services are appropriate for the capacity and human resources. And that we think that including academic and private sector laboratories in pandemic planning, especially for the point-of-care diagnostic centers, are really important when they are needed. And they should be included in any pandemic exercises. Our second review was looking at supply chain, procurement, and quality assurance. And we found that there's unreliable procurement and financing sometimes can lead to rupture of supplies and inconsistency in reagent availability. Quality assurance is ad hoc and with no uniform system adapted to the various tiers of diagnostic testing. So our recommendation in this area is for clarification of the funding for diagnostic testing in every tier of the healthcare system in the upcoming transition. And that we need to think about adapting and using the WHO Laboratory Information Management System, LIMS, for timely alerts for procurement and quality assurance. And also, even though the lab information system does not specifically have a system for alert of that you need to be procuring the next batch, but I think the algorithm could be put in to say if so many tests have been used out of the last lot that was purchased, then it's time for the next procurement. And so the same can go for laboratory lab quality assurance as well. And then in terms of implementing stepwise the SLIPTER system, that would help in terms of thinking through getting as many labs certified for ISO certification as possible to ensure quality of testing and quality of the tests. And then finally, to develop and implement a regular and systematic quality assurance program for laboratories and for point-of-care testing. And with that, I will hand over to Professor Heyman for the next review.
Thanks, Rosanna. And the next slide shows the review of the structure and governance in expanding diagnostic and surveillance capacity. And what we've heard so far is that there can be a downward pressure on laboratories to really support at a more local level than they may be doing now. And what we saw in in this review, and I remind you again that this was a very short visit to Indonesia, a 2-day visit where we had many, many different views. And so we're giving you a cross-sectional idea of what we saw. Much of this may not be exactly what is occurring in Indonesia, but you'll be able to tell better whether or not it is, and if the recommendations we're making are really useful to you. We hope they are. So what we found in the structure and governance is that in the laboratories that we visited, and these were at various tiers within the government, there's a confusion about transformation. And this is clearly normal when there's a new project that comes in. And I'm sure that 6 months later now, this confusion is much less. But there was confusion of where and what was expected under each tier of the system. At the same time, private sector was not included in sharing of surveillance and laboratory information through the coordinating minister. And this was told to us by very many different groups. And again, this is a common problem in all countries, not only in Indonesia. The private sector is not interested many times in working with the government because their bottom line is quite different than the government's bottom line. Their bottom line is to make a profit many times and not to be too concerned about the public's health. Third, public sector sharing of surveillance and laboratory data does occur, as we heard from Chandra, with the human, animal, and environmental sectors, and it's shared on a One Health technical platform. But what we were told was that this does not yet go through the coordinating minister. And finally, academic and private sector surveillance and laboratory data from human and veterinary sectors does not appear to be shared with the public sector. So our recommendations in this, Rosanna, next slide. Next slide.
Somehow I cannot move it again, so I need to stop share and and do it again.
Thank you.
Sorry.
No worries.
Yeah.
Okay, so we're on governance and recommendation.
Okay.
Okay, next then. Okay, fine.
Yeah.
So this is recommendation 3. To review and clarify laboratory expectations and develop guidelines to meet the expectations during the transformation. And I'm sure that this is already well underway. It was less underway when we were there back in September. At the same time, create ethical and secure data sharing policies. Again, a problem in all countries. What data can be shared? How can it be shared ethically? And how could it ensure more equitable access to the data? So there need to be safeguards. There needs to be surveillance and laboratory systems for humans, animals, and environment that are working together. And there needs to be, trust needs to be built during interepidemic periods and not during the public health emergencies. So a lot to do with this One Health system that Chandra explained so clearly in increasing trust and increasing collaboration in these sectors at all times so that there can be rapid detection and response. And at the same time, regular risk assessment of disease threats in the public, academic, private, and human and animal sectors. And this can be done on a regular basis, as is done in the UK. Each month, they meet looking at diseases that are in animals around the world, trying to determine whether they might be a risk to human populations in the UK. And they meet regularly. They don't miss meetings, but they meet by Zoom, the environmental, the human, and the animal health sectors. So looking at this, this is just better coordination between all these different groups so that you can really detect and respond rapidly. Next. We also reviewed diagnostic and surveillance capacity across the public health system. And we found that surveillance and diagnostic testing at the Puskesmas level does not include animal and environmental sectors. You've done quite a good job, we believe, in setting up testing at the primary healthcare level, but it doesn't include the animal and environment. Excuse me. We found that outbreak response is limited in effectiveness by government policies that discourage use of tests that fall outside the policy. And this became clear to us when we were talking about outbreak response and how certain laboratories can only do the tests that are on the government guidance to that laboratory, and they can't innovate or do tests outside that policy. This may be an interpretation that they're making, which is not true, but it was an interpretation that the government was too rigid in what it's providing as guidance for tests at all levels in all the different tiers, that actually this should be adapted to the tiers. Endemic disease reporting was not felt to be adequate in many parts, that there were certain diseases which are reported, but not all from the community level. And laboratory information remains siloed despite the system that was developed to integrate this information. And this we heard from many different sectors that we discussed with. And diagnostic testing equipment for COVID-19 remains idle or is being used for screening of things such as HPV, but it's not really being adapted for sustainable use. And the question remains, how can it be made more sustainable so that it is a part of the national surveillance activities, which doesn't just fall into disrepair because it's not being used properly or not being used in a way that can add value to surveillance. So our recommendations in this area are, Rosanna?
Again, I
Okay.
cannot advance it, so
Okay.
I don't know what's wrong.
Okay.
So yeah.
Apologies to our colleagues.
Yeah. No. Okay.
Okay, so recommendation for diagnostic and surveillance capacity. Consider the use of new technologies such as apps as means of reporting surveillance information and point of care tests rather than laboratory infrastructure. And this could save considerable funding if in fact at the Puskemas level, as our colleagues from UNICEF pointed out, there could be laboratory in a box, which is point of care laboratory tests adapted to the epidemiology at the primary healthcare level, which could avoid spending increased funding on laboratory infrastructure and provide useful testing, which can be linked to more central levels and can be quality assured. So just this push to move things further into the community if possible, so as to create more equity and more equitable access to surveillance. Second is to create algorithms for diagnostic testing with an emphasis on point of care testing using those tests that Rosanna showed us earlier, with data connectivity at the community level, ensuring equitable access and real-time reporting. Linking surveillance and laboratory data to digital mapping, as you could see with the Flu by You surveillance system in the US, develop more permissive testing policies with input from epidemiologists and laboratory staff, especially for investigating potential outbreaks. And this could include in-service training to provide epidemiology skills to laboratory staff. Mapping and rationalizing the use of all existing laboratory equipment, including those high throughput systems at the central level, and consider promoting and facilitating local manufacture of point of care diagnostics. So a whole series of recommendations. Finally, strengthening diagnostic and surveillance capacity. We reviewed the Red Cross study, which was community reporting in one of the areas of Indonesia. And this really demonstrated the feasibility of community level surveillance. Community level reporting and understanding now is needed on how to scale that up. Innovations such as point of care diagnostics, digital mapping, and surveillance dashboards did not exist in Indonesia when we took a look back in September. And we saw that Indonesia has a field epidemiology training for medical officers, but not for laboratorians. So including laboratorians in epidemiology training will help them better use the data that they collect. So these are our recommendations. Develop capacity to implement translational field research in order to better integrate new surveillance and diagnostic testing capacities. Develop and implement a field epidemiology training program appropriate for laboratorians so that they're concluded in the surveillance and not just sitting isolated in laboratories. And review and revise as necessary the excellent field epidemiology training program to ensure it's fit for purpose in view of newer innovations in surveillance and diagnostics. Finally, laboratory research is very important, and it's not clear how necessary research is to many within the country or will be, and especially when novel pathogens are identified in order to ensure best possible outbreak control, nor is it clear how laboratories will participate in drug and vaccine trials and other research activities during outbreaks. So recommendations in this area are provide resources to invest in open nucleic amplification technology platforms in laboratories, because this is the only way that you can really rapidly identify unknown pathogens. This includes things such as 16S ribosomal RNA gene amplification sequencing, which can be done at a fairly local level. Develop the capacity for wastewater environmental surveillance. I know it is going on for polio. It was going on for some SARS coronavirus too. This is important to continue to develop this for other infections, such as cholera. When cholera occurs, you may be able, in fact, to find it first in wastewater, a whole series of things that permit you to identify rapidly through the environment what's going on in human populations. Link academic research institutions and public health laboratories and together to initiate collaborative research during inter-epidemic periods so that they're used to working together when unknown pathogens are identified or suspected, and ensure resources for laboratory research to provide data for policy and critical public health decision-making. So finally, just to summarize briefly, there are major summaries in our report. Following some of the above recommendations, Indonesia can strengthen surveillance and diagnostic capacity, making more equitable access to surveillance by beginning to think about participatory surveillance for communities upwards, alerting the government of the need for additional support as required, making it possible to detect and respond where and when outbreaks occur. Engaging communities in public health emergencies and equitable access to diagnostic testing at the primary healthcare level to strengthen healthcare systems at all levels, leaving no one behind. And finally, by doing all this, there's real-time understanding of disease events, where and when they begin, with digital mapping of laboratory data to facilitate rapid public health action. So that's what we've had to say. Thank you again to our colleagues in the ADB, especially to Bia and her team, and also thank you to our colleagues in Indonesia who received us for the 2 days and stopped their work to help us really understand what's going on. So thank you again, Bia, and back to you.
Thank you so much. Thank you so much, Prof. David and Prof. Rosanna. We have quite limited time for the Q&A, but anyone who have a question, please pause in the Q&A session, and we are hoping that we can answer your questions. But there is one question that I think I can post to, I can talk to that today, and then if anyone have any response to that. This is from Dr. Enda, and Dr. Enda is one of the people that we visiting on September from the laboratory surveillance of the Ministry of Health. She asks about to improve the capacity of early detection and preparedness of potential outbreak disease at country entrance at cross-border from travelers. What do you think that health quarantine office from Ministry of Health can be strengthened their capacity with point-of-care molecular platform to early detection EIDs and fast emergency response? Maybe Rosanna, you wanna answer that, or David or Prof. Chandra?
I think David is more experienced with this. Cross-border, it's always a problem, right, in terms of testing. And I think during this COVID pandemic, there's been such a mixture of different requirements by different countries for entry, right? So, David, what do you think?
That's absolutely right, Rosanna. There's been real confusion at borders, thinking that you can stop disease at those borders by either closing the border or by testing. And this certainly, I think Chandra would agree with this. This is certainly something that is important early in a pandemic because you can maybe slow the spread of a pandemic. But the best guarantee for border security is good surveillance and detection everywhere at the community level, because people who cross that border go anywhere. And that's why if there's a good, strong community-based system of detection and diagnosis and response, you can have the most secure health system. I don't know, Chandra, maybe you could say a word about that.
Yeah, actually, sometimes, during this pandemic, I feel sorry for my friend who working in the port of entry, because the burden become so high. You know, Firstly, we have to taking the problem at the source, not at the recipient. That's the best way. Even at the recipient, it's not only everybody knows that even if it is a fever, people can take some medication while going through those sensor, so it's no longer fever there, and after reaching the hospital. So it should be a comprehensive system, not only the port of entry itself. But I think what Dr. Anna question was, maybe Rosanna, you could help us also Indonesia. Is there any kind of specific equipment you are talking about, handheld and easy to use, those kind of things? Maybe something, even though we know it is not only the burden of the people part of entry, but if there is something, some kind of quote unquote magical equipment can be used, that would be better. sorry,
I,
sorry to use term magic. It's not really magic, but anyway.
we all wish we have something that could magically, just test and find any pathogen that is in the room, right? But unfortunately, I think the even testing I think people have talked about testing the in the plane, the air. There's just not enough pathogens in the air that you could test, and not everything is transmitted by aerosol as well, right? So it is very complex to try and figure out what to do. Yeah, David.
And political leaders like to do this because then they can say we're protecting our people. But in fact, the only guarantee is good, strong, community-based detection and response mechanisms. And this false security of a test at a border just is the wrong way to proceed. For good health security, it has to start from the bottom up.
Yeah, but again, that is politically very, sensitive. People, the politician might still saying that, no, please prepare our border better, etc. So if there is something that, so you miss your job, case is coming to the country because port of entry is not working quite well, which we know is not correct. But yeah, that's
yeah. I know. I mean, at airports, they're still using those infrared sensors for anybody who has fever, right? So we know that there's been people who had Ebola, had a fever that didn't get detected by those infrared sensors. So they're just, they're more for show than anything else. Yeah.
But show is important sometimes.
Yeah, I guess. To make a statement. Yeah.
Thank you everyone, and I'm sorry, in light of time I will not able to take another questions, and we will go through the closing remarks, and Dr. Eduardo Banzon will give our closing remarks. Dr. Eduardo Banzon is the project officer for the TA 6767. He is a principal specialist in the Human and Social Development Sectors Group of the Asian Development Bank and honorary visiting associate professor in the National University, Singapore Soci Hawk School of Public Health. He's also the champion of the universal health coverage, and he was the president and CEO of the Philippine Health Insurance Corporation. Dr. Banzon, whenever you are ready.
Thank you, Bia, and thank you, Professor Chandra. And by the way, Rosanna and David, I'm also a proud alumnus of the London School of Hygiene and Tropical Medicine.
Me too. Me too.
Okay, so we have a London School mafia. Sorry, mafia here. This has been a very interesting. It's been very interesting. I actually told Bia that I don't need to talk, but I think they forced me because I think it's really great to listen to what's happening to, in a sense, Professor Chandra. We have been quite impressed, and to our friends here from the Ministry of Health, on what Indonesia has been doing in its health sector transformation agenda. You know, we have been talking with lots of countries, and they talk about strengthening their public health laboratories, and we really commend countries in Asia and the Pacific. But the effort that Indonesia is doing, this is really rapid scaled up. This is transformational. And we are now looking at what's happening here, so it becomes lessons for other countries that we are also supporting. But and the way that Indonesia is doing it, presented by Professor Chandra, where it's not just labs, it's actually connecting it with information system, connecting it with the rest of the system, and how, in a sense, you should not look at public health laboratory, you know, in a silo. I think is really wonderful. Now, what we also see, as what David and Rosanna said, basically, there's still a lot of lessons. Still lots of space for Indonesia to move forward. Now that they have taken huge steps in strengthening their public health laboratory, I think there's really now opportunities for Indonesia to really step to a little bit more. And we know what's happening. The point of care diagnostics, this has become sort of a game-changing. Everybody loves to talk about it, but people don't really know how to do it. And it's really great to hear lessons about that. Strengthening the community health workers. David, the Indonesia is really doing the Posyandu cadres is supposed to be the first line now of their diagnostics. And how the Posyandu cadres will be able to do it, I think this is something that we in ADB would really love to be part of the journey with Indonesia. So I would like to thank again everybody. We look forward to continuing our support for the Ministry of Health, for the health sector transformation. We look forward to work with you, Professor Chandra, with you, David, with you, Rosanna, and Yi is here, my colleague, who's based in Indonesia, in Jakarta. Probably will give her, Yi, if you're still there, we'll love you to jump in and close this with a few words on what we're trying to do and in our work in Indonesia. And by the way, we're also doing lab work in other countries, and I'll be bringing all three of you soon to other countries as well. Yi, are you still there? Can you jump in and close it? Oops, I think Yi has left. Okay, so allow me now to close everything. And again, thank you, everyone. Thank you to all those who've listened, and thank you to our wonderful resource person, and looking forward for more collaboration. Thank you. Bye-bye.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Salamat po.
Salamat. Salamat sa